Hello and welcome to Seconds Count. This is the latest edition of the Northern Ireland Ambulance Service podcast, which brings you behind the scenes of what happens within the ambulance service. I suppose most people, when they dial 999, are expecting that a yellow ambulance will turn up at their door and treat them and bring them to hospital. That is an old standard way of delivering ambulance services. But thankfully, over the past number of years, the Northern Ireland Ambulance Service has progressed, and we've brought in a lot of new initiatives that will help us, first of all, to manage the patient flow through hospitals and also to manage our own resources as best we possibly can. This is all done for the benefit of the patients. Today, I'm joined by Karl, who is our lead for alternative care pathways. Welcome, Karl.
Thanks, John. Happy to be here.
And he's going to talk to us about what these changes have been in the past number of years. So, Karl, question is, what have we done in the past number of years to make the delivery of our service more streamlined and more beneficial for patients?
We've done lots of things, John, and you're absolutely right. What we've seen over the last number of years, NIAS has very much been trying to innovate and change the way we've delivered ambulance service and pre-hospital care, as it's referred to. But that's not just here. The wider UK and indeed the wider sort of the world have been sort of looking at that, and it's a way to, I guess, effectively manage demand, but also get the right care to the right patient at the right time, first time. And to make sure we do that and deliver it in such a way. So I suppose from a very high level, what has NIAS done? We started a number of years ago introducing what were then called alternative care pathways, and those are pathways that were then open to our ambulance clinicians or paramedics to use as alternatives to simply conveying patients to an emergency department for assessment and ongoing treatment.
And why would we want to do that? Why is the ED not the best place to bring people?
Quite often not, and indeed even 10, 15 plus years ago, there's been some very good comprehensive reports published in the UK that show that actually high percentages of patients that ring 999 in a crisis, ultimately once they're assessed by our clinicians, ED is quite often not the best place, and their presentations can be managed more appropriately, safely, more cost effectively, but also to the wider system benefits, quite often in their home or through community teams.
So what are some of these presentations that then our clinicians will decide there is an alternative to ED? What sort of presentations would that mainly be?
Yeah, so there's quite a lot. I suppose what we're seeing increasing numbers of is frailty and how we manage that in the community. So that is something that I suppose when the NHS was first established was not to the same scale that we're seeing certainly now. And quite often we see with our frail, more elderly patients that ED not only is not the best and most optimum place that they can receive their care, it can actually cause them sometimes some harm, especially when we unfortunately hear about those ambulance handover delays and the waits in ED, and they get to that ward level definitive care. Actually managing patients, those patient cohorts in the comfort of their own home, where they're more familiar with surroundings. Not only does it quite often have better clinical outcomes, certainly no worse clinical outcomes when done appropriately, but actually when we look at 6 and 12 month post sort of intervention, if you will, those patients are actually still at home managing post that rather than maybe deteriorating and deconditioning into maybe care.
So does that alternative not only clinically help them, but psychologically for frail and elderly people, there must be a positive input for that, because as you quite rightly alluded to there, the frail and elderly do feel much more comfortable sitting in their own home, and as long as they're aware that they're getting treatment, they'll feel much happier, surely, and that'll promote good recovery as opposed to going and sitting in an ED for any length of time, even going to doctor's surgery and sitting, because that worry and that anxiety is there. So does that have an impact in terms of alleviating that anxiety?
Absolutely. From the studies that have looked at sort of patient satisfaction and stuff, particularly we look at our hospital at home teams, which is a growing model, which is really encouraging to see here in Northern Ireland, and an increasing sort of model that our frontline clinicians and paramedics are using to refer to those frail.
So what is this hospital at home?
So hospital at home is primarily a pathway that is consultant geriatrician led, and our clinicians have had access to different models of it for several years in NI, but it's really encouraging to see that the model's being standardised across Northern Ireland, and that those teams particularly look at generally over 65 patients, or frail patients with underlying multimorbidity and such. And it's whenever they have like an acute crisis, so an pneumonia, urinary tract infections, things like that, and that these teams, rather than traditionally conveying someone who is quite frail, maybe 80, 90 plus, to an ED to, as you mentioned, decondition, and especially that fear and anxiety. And that's even before we consider perhaps some sort of hospital-induced delirium or hospital-acquired infections, that if these teams can manage them appropriately, give them, and the clues in the name, hospital at home, it's hospital-level care.
Yeah, that's what I'm going to ask.
Yeah.
Our clinicians will go out and they'll say, we want to contact hospital at home. Who comes out? Is it just one person? When you say a team, what's that team made up out of? Because when you go into the ED, you have a team because there's so many people swarming about you and doing different things. What's that hospital at home team actually look like?
So they are big multidisciplinary teams, and with a range of multi-professionals in them. And each of the team will, I guess, look different to each patient. But I mean, it could look from an initial assessment from one of our consultants or one of the team's consultant geriatricians. You have advanced nurse practitioners, you have occupational therapists, physiotherapists, and they can directly refer into radiography as outpatients and stuff if they need to do things like that. They've senior pharmacists in the team, and wide nursing care, and falls assessment teams, they plugged into that within the trust as well. So they really do get the full range of treatments that they could get, rather than the physio coming to see you in a ward, that physio will now see you and assess you in your home, which is actually probably a more accurate assessment of your capabilities in your own home, when that physio can see how you can manage your own home rather than a ward, which is different from your own home. It doesn't have the stairs, doesn't have the obstacles, stuff. So there's those almost, I guess, initially were hidden benefits and ones you don't initially see, but it brings all that out to you.
And how long has this hospital at home initiative been going?
So it's been going for a number of years, and what we've seen in the sort of last real couple of years is there was a range of teams. Certain trusts refer to them as acute care at homes, other trusts refer to them as enhanced care at homes. Some were senior nurse led, with general practitioner oversight. Some were consultant geriatrician led, but the UK as a whole has generally now moved to those hospital home teams being consultant geriatrician led, which is that those senior specialist doctors being able to provide that very bespoke oversight to that patient cohort and really tailored care. And they've generally all bolted on the same generally MDT teams. Unfortunately, the thing is we can't seem to scale them up quick enough for the demand, but we are certainly seeing increased use of them, which is good.
So the benefit of them is, as you've outlined, is very, very clear for the patient. That does well for the patient. From our perspective, when our crews will go out and our clinicians will assess the patient and decide they want to contact hospital at home, how is that done? Do they just say, look, I want to phone somebody and somebody else will come out and see you sometime soon? How's that worked through?
So basically, the initial part of it looks, I guess, very similar to the traditional ambulance model. I'll talk about what it would look like for one of our clinicians to see first, and then we'll maybe talk about sort of how the clinical hub might do that later on. But essentially, those patients would ring 999, or sometimes even be referred to the ambulance service through primary care. Their primary care physician might feel, following a telephone consultation, it sounds like that patient needs an ambulance. Our clinicians would attend, they'd complete a holistic assessment for that patient. And once they've completed that assessment, if they feel that actually, this patient seems to be meeting that pathways inclusion criteria, it basically then is a clinician to clinician conversation where our paramedic, for example, will phone that consultant geriatrician or lead nurse that's receiving for that team. They'll give a structured clinical handover, and then between them they'll decide, actually, yes, A, we have space in the team, and B, that looks or sounds like something we can manage. So they would agree we'll attend within 1 hour.
They can do that. That's what I was going to ask you next. Can they attend as quickly as that, or is it sort of you're on a waiting list, will be within a day or 2 days or 3 days? And that's really good to hear that on some occasions it's really like an emergency response.
And it pretty much is. I mean, the target for all hospital homes is within 2 hours. So generally, unless of course it's clinically appropriate to wait a bit longer, the teams tend to be out within 2 hours to start that hospital level care. And actually, quite often you see now with our protracted delays of hospital ambulance handovers, is those patients probably getting the care quicker than if they actually went to ED.
Yeah, and that's a good thing. That has to be a good thing.
Absolutely.
It's, the benefit of the hospital at home team. Right. So you did mention there just Clinical Hub, because I understand that Clinical Hub is also in some ways an alternative to taking people to ED. What is the Clinical Hub? Outline it for the people who are watching this podcast today.
Sure, yeah. So our clinical hub, some of our colleagues probably will remember the team or the term, the CSD, the clinical support desk. So that was started a number of years ago with a small number of clinicians. And what they did was they were embedded within our control room, and they would review calls that had come through the 999 system, being triaged by our EMDs or emergency medical dispatchers, and they would phone certain patients back. And they would then carry out a remote telephone clinical consultation with those patients, and they would identify ones that potentially could be managed with some self-care advice, maybe discharge them with some worsening care advice, or they could even refer them to these hospital home teams where it was obvious they could plug them into that.
Right, okay, so you talk about discharge, right? How's that received by the caller? Because I'd have thought that most people who phone an ambulance, phone the ambulance service, feel that they are really unwell, and would be expecting some kind of a clinician to arrive at their front door. How is this advice of self-care, etc., received generally by patients?
Generally, it's received very well, and we've carried out some sort of follow-up questionnaires on initiatives we ran within the clinical hub, and yet the feedback has been very positive, I suppose. And the reason we see that is because for a lot of patients, it's the uncertainty about their health trajectory of that acute presentation that causes them the most anxiety. So if they quite promptly get a phone back from one of our sort of experienced clinicians in our clinical hub, who runs through a very thorough, very comprehensive clinical assessments, addresses their needs and concerns sort of on a patient basis, and then can work out that plan with the patient and say, well, actually, we could avoid emergency department because it's not indicated. We don't need ABC. We're reassured by what you're telling us, and we our differential diagnosis may be this, and we think that could be managed by a bit of self-care, a bit of attending the pharmacy, and really get some sort of over-the-counter medications, things like that. For the patient, that means that care episodes kind of resolved then for them, and they have a clear pathway. I suppose ambulance is coming out taken to ED, they still don't know what the outcome is. Am I going to be admitted? Well, how long will the waits be? Especially with, I guess, the pressures the system is under now. Being able to know that you can safely avoid that and appropriately avoid that is actually well received.
Yeah, and I take it would be a norm that they'll be left with the advice that if they deteriorate, the condition changes, to phone us back.
Absolutely.
It's not a definitive, we've dealt with you, you're gone now. We're always there again.
Absolutely. It's very much like it's not like you get one phone call and that's it. You've done absolutely not. All our clinicians will give, even our clinicians that attend face to face will give our sort of what we call worsening care advice. So if things, this is what we anticipate your acute care episode will look like, but if it doesn't, because ultimately we're in unscheduled care, things don't always go as we anticipate. It always is. Some people get worse, some people get better, and that's why we give that worsening care advice. Well, if it doesn't follow that trajectory, this is the plan as to how you would re-escalate and how you would manage you then. And reassuringly, we monitor those sort of what we call like recontact rates, and they're in line with what we expected in wider UK practice. So that reassures us that our clinicians are doing a good, safe, and effective job.
Yeah, and reassurance for the public is very, very important from our perspective, because I'm just while I'm listening to you, I wouldn't want the message to go out that you'll phone 999 and sometimes somebody will phone you back. If it's a category 1 call, it doesn't happen with category 1 calls. You get the immediate ambulance response. This clinical hub will intervene on what category of calls?
So typically, we go after lower acuity calls, typically, but our clinicians, we have senior clinicians.
Now, lower acuity is a heck of a clinical term. What does that mean?
When I say lower acuity, it's things that are on category 1, I suppose. Ones that aren't deemed through our sort of our initial 999 triage system as immediately life-threatening. So our clinicians, traditionally, when it was a smaller team, would have only reviewed a small percentage of 999 calls. But what we've actually seen as we've grown the clinical hub over the last couple of years, we put in sort of senior clinicians sort of, I guess, to navigate and review the entire and wider what we call as our sort of our waiting calls. We would review sort of really any call, and any call that would look suitable, we would then phone it back. But another element our clinical hub bring to the table is patient safety oversight. So they aren't just reviewing ones that might be managed for community or might be managed with a bit of self-care and advice in order to protect ambulance capacity. They're also looking for ones that, for whatever reason, might need upgrade or need a prompter response. And again, when we look at the data that we've seen from that, those calls that do get, I guess, prioritised by our clinical hub and attended by our crews, the finding on the scene is they are identifying those sicker patients and ensuring that they get the quickest response, which is again a very reassuring thing.
Very, very beneficial. So how much of this, got to ask the question, how much of this is just to avoid us sending out ambulances?
Ultimately, it should never be simply just about avoiding ambulances, because what we want to do is we want to make sure all decisions are patient-centred and patient-focused. On an individual level, but also a system level. If as demand has increased and our incoming, as you well know, our incoming 999 call volume has increased very much over the last few years. We have to manage that, I guess, appropriately. And it wouldn't be appropriate to send blue light racing ambulances, fast response vehicles, helicopters, for example, to everything. Everything should be managed appropriately, because then that means those resources are free for the people that really need it.
And that's a key point. We're keeping ambulance response for those life-threatening situations, because if an ambulance is tied up, if it's going to a lower acuity call, a serious call, and a category 1 call comes in, it can be diverted. But if they've arrived at the patient and they're dealing with somebody with not a serious fall or anything like that, they're then tied up. So as part of this is about trying to keep our resources for those who actually need us the very most.
Absolutely. It's about being intelligent with our guest dispatch and ensuring that what we dispatch, we get it right first time, rather than, for example, we dispatch an inappropriate response to, we dispatch maybe a fast response car when actually that patient needed an ambulance to convey them, or we dispatch an ambulance with 2 clinicians on it, a very expensive, lots of equipment, life-saving equipment in there, for someone that actually just needed referred to primary care that potentially our clinical hub could have managed. And it's, for us, for a health system, it's a much more cost-effective means, but it's also a much more beneficial means of managing that care episode for that patient. And not only do they get, I guess, the right care first time, especially those going back to the frail patients we talked about earlier, if they avoid unnecessary and unindicated trips to emergency department, they avoid what we call all the potential iatrogenic harm, hospital-acquired infections, pressure sores and stuff, the things that they could be at risk at if they were inappropriately taken to ED and then managed actually very appropriately for their condition through those teams and stuff in the community.
Yeah, it's just occurring to me as you're talking, about, again, these less serious calls and about the caller. I'm just wondering about the caller sometimes, because it's a long time ago, as you're aware, that I was out on the road. If we went to a call and we didn't think the patient needed to go to hospital, but the patient insisted on going, we didn't really have any choice. We had to take them. I don't know if that's changed or not, but how does that fall in with the likes of the clinical hub? If they think, no, you actually don't need an ambulance, but the caller says, no, well, I want one. What happens there?
I suppose there's probably no easy one answer we give that. It's very much case by case. We certainly we support our clinicians to have those conversations and I guess again make them very patient centered and explaining. Quite often we find that when we explain the rationale as to why we think actually this is more appropriate for you. I suppose even as we were talking about like the hospital home teams, people are, but I would like my family member to be seen in hospital, and we say, well, actually by getting this team there will be nothing you cannot receive in the safety and the familiarity of your own home. And quite often patients, I didn't realise that. I thought hospital level care was like the gold standard. So, actually we can bring that to you here. And quite often that negates those sort of, I guess.
Yeah, and I wouldn't want to paint the wrong picture that this happens daily. It's just the odd exceptional person, the odd difficult person who's just wondering how it's dealt with. But again, as you say, just the same as our clinicians are very well trained on how to deal with patients, difficult patients on the road. The clinicians in the hub, they will be trained with how to change people's thought process and perhaps realise that it's to their benefit.
Absolutely. And I suppose trying to say selective is maybe the wrong term, but I suppose again it's just that taking every opportunity for health education as well, and to say, well, actually this is the benefit of it to you, rather than I suppose trying to force something that a patient didn't really want onto them, and our clinicians are very good at sort of putting that message across.
So the hub has made a big difference, has it?
Yeah, no, absolutely. We've seen
who staffs it? Is it just ordinary paramedics?
It's actually a range of clinicians. So what we have then is over the last couple of years, we have established, we have paramedics in our clinical hub. We have a small number of nurses. We have clinical support managers, which would actually act like our duty senior clinician. We also recently started last year a program for our first trainee advanced paramedics in urgent care, and as part of their program, and indeed part of their education and ultimately their rotational model that they will move into once qualified, they'll rotate through the hub as well. So we have trainee advanced paramedics in the hub as well.
Okay, but the main cohort of the paramedics that are there, are they additionally trained to the paramedics in the front line?
They are, yeah. So they all receive, I guess, clinical decision-making tool training specific to their role, remote clinical assessment training when they join the clinical hub. And one of the things that we, a lot of people find when they come to the clinical hub and they enjoy is we build in education time. We have, sort of every few months, we have team education days where we focus on, I guess, learning from anything that's taking place across the trust and how can we improve our care. And we also then have an opportunity for clinicians to go through remote clinical decision-making modules with one of the universities in England that offers that.
Yeah, and so how do you, on an ongoing basis, quality assure the advice that's given by the clinicians in the hub? I know that the control have their own quality assurance section. Does the clinical hub have such a thing as well?
It does indeed. So it's quite a robust clinical audit process, and beyond obviously their initial training and clinical sign-off by sort of the experienced clinicians in the hub, they have monthly audits. So calls are chosen at random. Will it be reviewed by peers within the clinical hub, marked against obviously the internationally validated sort of Manchester triage tool we use currently, to ensure that basically not only is it clinically safe, but the outcome they get to is appropriate, and where we can identify, fine-tuning or, opportunities for like maybe, other pathways and stuff to be used, then we can feed that back to the clinicians and hone their skills.
Yeah, so for the patient then, it's important for them to realise, firstly, that the clinicians in the hub are motivated because they have volunteered. Nobody's forced to go and do it. There's recruitment processes for it, and then they're given training, and then there's quality assurance taking place, just to make sure that it's always the highest standard possible in terms of what they do, and sometimes that's very much the benefit of the patient not having to go to the ED.
Absolutely, yeah.
Right, so in terms of is there anything else within your remit that helps us to properly assess patients that maybe don't need emergency department? For example, I'm thinking of mental health, right? There's always this debate about whether mental health patients is ED the right place for them? Where do we sit on that at the minute?
Yeah, so I mean, I suppose unfortunately just our system in NNI is a lot of patients end up in ED. That ED isn't the best place for them, not just mental health patients, simply because our system is kind of still designed that way inherently, and that's sometimes the only door that's open. So and that's very much the case for mental health patients. Very excited to say today we've just our new mental health lead has just started with the trust, and brings a lot of experience with them. And we also have and now it's not only mental health, but they help support patients with a range of sort of multimorbidity and complex needs, is our sort of in-trust complex case team, we call them, and they work with patients. A fair proportion of them do have poor mental health. And we
complex case. What is a complex case? What does that mean?
So it's essentially there's a definition where basically patients that would contact the ambulance service through the 99 system a number of times within a month over a several month period, that would then be identified by this team reviewing the incoming calls and identifying those complex cases, because just typically most people only ring an ambulance maybe once or twice in their life, whereas obviously these patients have complex health needs and therefore are contacting unscheduled care and the emergency services more frequently than quite often, quite a bit frequently above the averages, and this team would review that and they would make contact with those patients, understand their underlying health needs, and then try and basically signpost them, plug them in with the right community teams, multidisciplinary teams within the community, to, I guess, ensure that they have access to the care they need. And quite often the team find that the patients are contacting us in crisis because they haven't been connected to those community teams. They exist, they just haven't been plugged into them, I guess, historically in the right way. And that team, through their work, when they carry out any of the interventions, whether that be meeting, linking them with their patient's primary care and ensuring they have the right package around them, we see that very quickly a decrease in the calls that come through on an 999 system from those patients, because they're getting, I guess, the more appropriate care, and they know where to go for that.
And does that then, it seems strange to ask this, but obviously these patients are identified, and once they're put into a proper system, does the working complex case team diminish?
It doesn't, unfortunately. The complex case team are simply just due to the size and, I guess, the increase in volume we've seen through the 999 system over the last number of years. They can only get to so much of the I guess the callers that would call us more than average, any sort of calendar month. So as that reduces, and ultimately more patients with complex needs come on. So they do. So they never run out of work. Quite the opposite. They have a bit of a backlog. So they even, like, I suppose, comparable to our clinical hub, they can only manage so much. If they had more, if the teams were bigger, then ultimately, yes, they could manage a bigger percentage of those patient cohorts.
Yeah. Right. So is there anything else, Karl, that's going on in the alternative pathway world?
I think for me, it's actually the last few months it's been a really exciting period. We also have, led by our clinical service improvement lead, a number of clinical pathway leads that work proactively with all the trusts to ensure that our clinicians have access to the pathways. And what we're seeing is a real appetite now over the last few months, driven from department down, where the minister has announced about the ambition of a neighbourhood care model, and for us, we're really excited to see that. Because
so what does that mean?
So essentially, it means, I guess, another way to put things like hospital at home. It's care in neighbourhood. So in Northern Ireland, we actually have a much higher percentage of our patients are treated in a hospital bed than if you look at England, Scotland, and Wales. So we're a bit behind on the neighbourhood model, if you will. Our hospital at home teams, for example, are still not as big as maybe hospital home teams in Scotland, so they can't take as many of the patients. So the minister wants to see more patients safely and appropriately managed in the community for the benefit of themselves, but also the wider system as we grow.
So all the pathways that you've just mentioned there, are they available to all our clinicians in all our different areas? We've got 5 different areas that we operate from. Are the trusts all aligned with these pathways?
Unfortunately not. In Northern Ireland, we're, I guess, unique from an ambulance perspective in that we are one ambulance trust that covers the whole region. But we 5, as you rightly point out, hospital trusts or geographical trusts that we plug into. And unfortunately, there is variance among them. And quite often the message from ambulance services is like, where there's variance, that drives ED conveyance. And we want to see standardisation across the region. And that's what's been really exciting the last few months is, I think there's been a real appetite among the trusts from the department to help us get to that, because that will work out better for well. Because we have clinicians who, for example, would predominantly work in, let's take Belfast Trust, but they may attend a call in Antrim. The inclusion criteria for pathways up there might be different. That creates barriers for our clinician to refer. And I guess, yeah, we don't want that. We want streamlined, where possible, single point of access. And that's what our pathway leads are sort of proactively working towards. And we see an increasing appetite within the trusts to see that, which is really good.
And that's bound to be for the benefit of the patient. Again, everybody, the health service gets a bad press. But at the end of the day, what we tend to do and what we always put at the centre of our focus is everything that we do is for the benefit of the patient. Mm-hmm. And we've got to continue that. And we've got to work with what we have, work with the health trusts that are there, and providing what they provide, we will utilise it as best we can. And it's good to hear that everybody's trying to drive in the one direction, and we look forward to those days coming. Karl, thanks very much for coming in. It's good to hear you.
Thank you.
You did mention one little thing there, that your mental health lead has just started today.
Mm-hmm.
Can you put them on notice that they will soon be sitting in that chair, if at all possible?
I can, and they actually seem quite keen for it.
Well, that's very good. We'll get them in sooner rather than later. Karl, thanks very much for coming in.
Okay. Thank you.
Okay, so that's the latest episode covered then, about alternative care pathways. You know, it's not just about an ambulance coming out and taking people to EDs, and it's not that these are to stop us doing that. This is all about what's best for the patient and to allow us to deliver to those patients whose need is more immediate, more urgent, more clinically urgent, and more serious. So I hope you've got a bit of an insight into what the alternative care pathways within the Northern Ireland Ambulance Service are, and we look forward to talking to you shortly about our next episode. Thanks now. Goodbye.